Thank you guys all for being here. This is the second year that I've attended this, so I guess first of all, thanks to the Scleroderma Foundation of Greater Chicago. This is an excellent event. Really excited to be a part of it again. Talked to a couple of you guys already, and I'm going to be sticking around throughout lunch as well, so feel free to come up if you have any questions that we aren't able to get to about lung problems, and we'll get started. So our topic today is it's a little bit clinical, and then we're going to transition to talking a little bit about what treatments exist for scleroderma, lung disease, and then a little bit about what might exist in the future. So we'll talk about clinical trials, clinical trial enrollment. I know we've got some brochures about some active clinical trials we're working on over at Northwestern at our booth over here, so if you're interested, certainly come over and say hi. All right, just a few disclosures. Our objectives today, understanding scleroderma, learning about what clinical trials look like, and then ultimately talking about those treatments like we talked about. So kind of the first thing that it's important to know is, we talked about skin involvement in scleroderma, we've talked about GI involvement in scleroderma, and now we're going to talk a little bit about lungs. And to understand about lungs, one of the hardest things that I do in clinic is to explain to people, what does interstitial mean? It's kind of a weird word, one that we don't use a lot. And so trying to understand where we're talking about this activity happening, this problem with the lung. So first off, obviously you've got your lungs, nice pink sponge-like. They're sponge-like because when we look at them up close, they're mostly filled with these air sacs. You can see in this picture, the tissues, the red part, the lung tissue, and the open spaces are just air. Okay, and so it's mostly like air sacs. So if you picture your dish sponge maybe and all those little kind of bubbles in there, that's really what the lung looks like and what it feels like. We learned that kind of right at the beginning of medical training when we started anatomy class. One of the weirdest feelings is touching what a lung feels like. It feels just like a sponge. And so mostly air, the lung absorbs that oxygen and gets rid of carbon dioxide. And so these air sacs, or alveoli, that we talk about, we've got a cartoon here to make it a little easier to see. So we got air coming in and out of the airways, and then we have these air sacs that have a bunch of cells in them, but really those cells tend not to get in the way because it's mostly empty space, and oxygen really freely flows from that air sac into the blood vessel, and that's the capillary that runs throughout all of the lungs and absorbs that oxygen from the lungs. In normal health, that's a really easy process. So when we talk about disease, what happens is that thin barrier, that interstitium, can become thickened, okay, and get scarred up. And I'm going to go back a couple slides because I always like pointing these out. These little blue cells in the middle here, these are what we call fibroblasts. And we start talking about fibers and kind of get the sense of what a fibroblast might do, is to kind of deposit some scar tissue or some fibrin. Think of it as just little fibers of connective tissue into this space. And as those fibroblasts get rid of or produce more fibrin in that space, it gets thicker, it gets increased distance. There's more stuff in between those air sacs and the capillary, and it gets harder to move that oxygen through. Okay, and so that's really that interstitium that we talk about in interstitial lung disease. And so that's kind of what scleroderma causes, is it activates some of this fibrous tissue and sometimes causes inflammation in these areas as well to be in this space that will impair the exchange of gases. So you can see here depicted is our oxygen coming in and carbon dioxide going out. And in a cartoon form, we see that it's a little bit harder when we have that thickened, more fibrous interstitium there. All right, so often in clinic, also we'll talk about CAT scans. And so CAT scans are these special x-rays where we can actually look at a 3D representation of what your body looks like. So normally when we think about diagnosing lung problems, we think, okay, well, let's just get an x-ray. And really, just your standard x-ray, your standard chest x-ray, isn't as good as we want it to be to diagnose types of lung disease that we see in scleroderma. And one of the big changes even in the last year since I last spoke at our gathering here, is the recommendations about who should get a CAT scan. Okay, and so we always, in the medicine world, want to play a little bit of a, let's not do it if we don't have to, because then we might find something that we don't need to know about that wasn't really important. So we don't do a lot of screening CAT scans, but over the last couple of years, 10-ish years or so, we've started doing cardiac CAT scans, we've started doing lung cancer screening CAT scans. And just in the last year, the American College of Rheumatology has recommended that everybody with the diagnosis of scleroderma should get a screening CAT scan. Okay, this is somewhat controversial. This came out of a big group of us, myself, Dr. Damati was included, and a big group of doctors from across the country came up with these recommendations based on evidence-based practice, but it really wasn't that evidence that triggered us to make this recommendation that everybody should get a CAT scan. Importantly, it was patients. It was patients who said, I want to know. I don't want to be in the dark about this. And so because we heard from patients, and the patients that were included on that panel have such a great voice, we've made this recommendation with the American College of Rheumatology to start getting CAT scans in everybody with scleroderma. So this is a CAT scan. I always go through a little anatomy lesson in clinic as well. So up here at the top is the chest. Down here at the bottom is your back. This is the right side over here. This is the left side over here. Right lung on this side and left lung on this side with the heart right in the middle. Okay, this is pretty close to a normal CAT scan here. We can see outside the body is black, and that's what air looks like. And so the lungs, we looked at all those air spaces in that slide that we showed a couple slides ago. The lungs should be mostly filled with air. Okay, and so they should be mostly black. These white things in the middle are blood vessels, and they're normal. Okay, so this looks very good, very much like a normal lung. When we talk about lung disease in scleroderma, that CAT scan looks a lot different. We'll focus on this part first. So again, we're looking at the right lung on this side and the left lung on this side, and we see a lot more white stuff, kind of a lace-like pattern along the edges there. And that lace-like pattern, the radiologist might call reticular changes, or fibrosis, or interstitial changes. And it's that problem that is that interstitial lung disease that we were talking about a few slides ago. And that ultimately leads to symptoms and ultimately leads to problems and complications. So you can see up here, I've got written out, scleroderma lung disease is very common in scleroderma. Up to 3/4 of patients with scleroderma will have abnormal findings if we do lung function testing. And up to 90% will have abnormal findings when we do those CAT scans. Okay, so it's not a rare thing. And that led us to, again, talk about screening CAT scans for everybody with disease, even early in the time of diagnosis. See the picture up top here, this is a pulmonary function test. Has anybody had pulmonary function tests before? Yeah, good. Yes. Dr. Richardson's doing her job. So it used to be that we'd just get pulmonary function tests to screen for lung disease, and certainly there was nothing wrong with that. But you can see up to 90% of people have these abnormalities on the CAT scan. It's going to be a better test for identifying early disease, early lung disease. These pulmonary function tests are so much fun. If you haven't done it, you really need to. I say that completely jokingly. I've done it once. It's a hard test to do, right? It's really hard. You're clothespin on your nose, and you're getting yelled at sometimes to blow, 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 blow. And then that's just the half of it, because you got to do it 2, 3, 4 times over again to make sure that it's a good test and that it's valid. To top that off, you get in this little phone booth-like device. So if you've got any claustrophobia, oh goodness, it's kind of difficult. Luckily, we have some other ways to do it if you're really having claustrophobia. But it's tough. I mean, in clinic, up on the 21st floor at Northwestern, the main thing that happens that's out of the normal range of daily activities going to see patients is getting called to the pulmonary function room. Somebody's feeling like they're going to pass out. And that happens frequently. So don't feel bad if that's been you before. That happens to everybody. It's a tough test, and you can get good at it over time. The first time you do it, it's hard. You can't follow the instructions. You are asked to do things like, pant like a dog, and then hold your breath for 10 seconds, and then exhale, and then, okay, well, and then we get this big readout of all of these numbers, and that's really confusing too. And individually, it may not mean something, but over time, the more of these that we follow, we can see how the lung disease may be changing. But this is also, just to say, pulmonary function tests and CT scans should be done on pretty much everybody with a diagnosis of scleroderma to detect this disease, because when we detect it early, and we'll talk about some of these treatments, we're better able to treat disease. So getting back to what is actually going on in the interstitium again, put back up here our nice normal looking lung with all these spongy little air sacs that are sitting in here. And this is an example of fibrotic lung. You can see those air sacs are still there, but look at that interstitial change there. It's pretty obvious. You don't have to be a pathologist, I'm certainly not, to recognize this is abnormal. This doesn't look like the slide on the left, all this fibrous tissue there. Now sometimes that tissue can look very inflamed and have a lot of cells in it, and we sometimes will talk about immune suppressing treatments to get rid of those cells. And sometimes it looks more like this, which is more fibrotic, and sometimes we'll talk about anti-fibrotic type drugs to treat it, which we'll get into in just a second. So how should we be thinking about this? So this is the current recommendation for active screening. So again, you have a diagnosis, and then you'll get pulmonary function tests and a CT scan on everybody. If everything's normal, then we probably just get yearly pulmonary function tests. If it's abnormal, then we try to figure out what type of disease we're looking at. Is this extensive already? Then we need to move toward treatment. If it's limited, kind of very mild changes, then we might want to screen more regularly and figure out if it's progressive before we treat. If it's stable, sometimes we won't. And that's the interesting thing about scleroderma lung disease. Sometimes it can be completely stable and may not require aggressive treatment. And especially later on in the course of disease. If you get diagnosed, you're more likely to get lung problems in the first year or two after that diagnosis. And then even if you did develop lung problems down the road, those are more likely to be more stable. And sometimes we'll treat up front and pull off therapy down the road. And it's somewhat of an art form to figure out when the right time to do those things is. Mentioned here, prognosis is good. So a lot of people with lung diseases like this come into the office having gone online and Googled pulmonary fibrosis. And pulmonary fibrosis is a very big blanket term that we can sometimes use to describe all different types of pulmonary fibrosis, all different types of interstitial lung disease. The bad form of pulmonary fibrosis we call idiopathic, or IPF, because we don't know what's caused it, meaning it's not scleroderma. Scleroderma, we know what causes it, so it's not idiopathic. But IPF carries with this very bad prognosis of an average survival of 3 to 5 years, which I think is a bit outdated, but that's a very scary number to think about. Scleroderma lung disease, much better tolerated. Not perfect, obviously. We're talking about a real systemic disease that causes a lot of problems, and lung disease is one of the biggest things that can cause big problems. But in general, instead of a 3 to 5 year time to mortality, then we're talking 10, 15, 20 years from the time of diagnosis. And sometimes even not, sometimes like I alluded to, things can become very stable and not progressive over time. The earlier we diagnose again is probably the most important thing. All right, I'm going to switch gears a little bit and talk about clinical trials, because any of these treatments that we'll finish our talking about have gone through this process already. Okay, so there's multiple medications that have been approved for the treatment of scleroderma lung disease. I've listed them here on the right, or left. Look at too many x-rays. Here on the left, and we'll go through the clinical trials that got these approved. I'll tell you a little bit about that story, which I think is a very interesting story. But yeah, recognize each one of these has gone through years and years and years of development in order to be approved for treatment of systemic sclerosis-related lung disease. So this is kind of a typical pathway to identification of a target, something we're going to treat, in order to get approved for use in patients. You can see up top we have kind of the phase that we're in. So first is target validation, where we identify what we want to treat, and then we have to find what will treat it, and then we optimize that treatment. We may start in preclinical testing, and so that might be like in animals. And then we move into phase 1 testing, which is usually where we find the medication, make sure that that we can use it without too much toxicity. Phase 2 are those slightly bigger trials that we monitor people with disease with the medication, so not healthy volunteers, but maybe people in this case with scleroderma lung disease. We'll enroll them in these trials. Phase 3 is where we get these bigger trials, hundreds of patients across multiple centers, usually multiple countries, and then approval to launch. So if you add up all of these 1.5 years, 3 years, 4.5, 5, 6, it goes on to 10+ years of development of these drugs before we can approve them for use. And as my colleague just said, the FDA rarely does approve some of these, and we have to use some of them off-label occasionally too. This is really why. It takes a long time in order for drug development to occur. What we have these brochures for that I was talking to you about over here, usually those are going to be phase 2 or phase 3 trials that are later on in the course of this. Early on in the course, we're talking about people in maybe Northwestern doing bench research on cells first and on computers maybe, and then moving that to our animal models, so usually mice and rats and things like that, before then ever introducing it into a human. Okay, and so when we talk about how do we, all of us, participate in these clinical trials, so these are the phases that the FDA calls for these trials, right? So phase 1, where we focus on safety of in finding the proper dose. Usually this is in healthy volunteers. In phase 2, we think about, is it effective, but really more so, what are our side effects? And we've gone from 15-ish patients up to less than 100 patients. In phase 3, we enroll multiple hundreds of patients ideally, although like we were just talking, scleroderma, sometimes it's a smaller group of folks than people with heart disease. And we really need those volunteers for these clinical trials in order to reach those hundreds of patients to know if the medications work. So we'll compare the new treatment with existing treatments. And then phase 4 is long-term monitoring. So after the drug's approved, are there any new safety endpoints that we find down the road? Okay, and so this is kind of the typical phase or typical way that clinical trials will progress. Now, kind of got some real-world examples for us today. So for those of you who are more interested or interested in kind of learning a little bit more than what we're going to talk about, you can go onto this website called clinicaltrials.gov. This has all the clinical trials that are approved through the National Institute of Health that are recruiting patients. Some have already been published, but anybody can go on here. I went on here on my personal computer, typed in scleroderma, interstitial lung disease, and how many, looks like, can't see how, looking over here, how many exactly, but there are 20 plus trials that were enrolling in various phases, whether some of these are even registries and not clinical trials where we're checking for new medications. And so you can go on and do that. You can click on any one of these and it'll take you to the trial design, who's running the trial, where the trial's coming out of. Do we have it at Northwestern? Do they have it down at University of Chicago or wherever you might be coming from? Another place you can do this is on the only other website I've ever told a patient to go to. Okay, bad information on the internet in general, but one of the best websites out there is one called pulmonaryfibrosis.org. And again, pulmonary fibrosis used as a big blanket term here, not just IPF, but all types of interstitial lung disease. And they have a fantastic tool that's called a clinical trial finder. And so on this, I went through for myself and I said, okay, well, I'm trying to find a clinical trial for scleroderma lung disease. And you can type in your age and your zip code and and what diagnosis you have, or what maybe you can look for a family member even, what diagnosis they have. And you can see they found 54 clinical trials enrolling here. And better yet, when they have some graphics on here that'll help you to understand how the trial is designed, things like that as well. So if you're interested in clinical trials, obviously talk to your doctor about it. But you can go on clinicaltrials.gov or pulmonaryfibrosis.org to identify what those clinical trials might look like. And these are changing all the time, right? So these are present from, updated weekly. So if there's a new one that gets added, you'll be able to find it very easily. So I threw a couple of these up here. Within clinicaltrials.gov, there were 4 actively recruiting therapeutic trials that were listed there in the United States. So just to kind of show you what's in the pipeline here, there's this one drug called belimumab. The clinical trial is called Bliss ILD. It's a GlaxoSmithKline product, and they're randomizing patients in this phase 2 to phase 3 randomized placebo-controlled trial. So what does that all mean? So phase 2 and 3 we talked a little bit about. Randomized means that you have an equal chance of getting the experimental drug, in this case belimumab, or getting a placebo, which is obviously like a sugar pill or sugar water. And we randomized to try to make it pretty even, that patient characteristics are similar between the two groups. Placebo-controlled obviously speaks for itself. We already talked a little bit about that. Now this drug is an inhibitor of B lymphocyte stimulator. So you know B cells are these white blood cells, and white blood cells trigger inflammation. So this is somewhere in the inflammatory pathway trying to halt that inflammation, those B cells from being activated. Okay, so I don't know if it works. That's why we do these clinical trials. At the end of this clinical trial, it might tell us this drug is great. It helps to improve lung disease. Or it might tell us, no, it was no better than placebo. And then we'll go back to the drawing board and enroll in more clinical trials. And there's way more negative clinical trials than there are positive clinical trials. You know, we would love for them all to work. And at some point, somebody thought, you know, this is a great target. Let's try animal models, okay, put it in a mouse with pulmonary fibrosis and see what it does. Oh, well, that looked okay. Okay, well, let's enroll in a phase 1 trial. And those phase 1 trials are usually with those healthy volunteers, making sure we can find the correct dose that's a safe dose. Okay, well, that looks good. And then we move to a phase 2 trial next. And it's only after all that work, which, if you remember back to that slide, that's probably 7-8 years of work to get to this point where this drug is, to where we've taken it and we can say, okay, well, let's try it in humans now. The next one that I found on clinicaltrials.gov is this tulisokibart. It's the trial is called Athena, SSC-ILD, by a company called Prometheus. And this is a TNF-like cytokine. TNF is one of these inflammatory proteins in your body that recruits more inflammatory cells. It can kind of cause a very robust inflammatory problem. And so this inhibits that recruitment of inflammatory cells. Same thing that we were talking about for the one above. It's on that inflammatory pathway trying to reduce inflammation. The next one that I found is called vixarelimab. Trial's called Moonscape by Genentech. It's a phase 2 trial. And this, again, is in that inflammatory pathway. There's a whole lot of funny words here, but basically trying to reduce inflammation by inhibiting one of those pro-inflammatory proteins that we call cytokines. Okay. Lastly, I'll realize I'm pointing at one side and not the other. I'll point at this side now. We have CAR T-cell therapy, which is a really interesting therapeutic option that is just coming into prime time now. And so these are T cells that we've kind of selected out of your own inflammatory cells, your own white blood cells, that we can modify and make attack scleroderma proteins. And so this is really interesting, and I actually saw a brochure over on the table about this CAR T-cell therapy. We're using this for a lot of things. It's really, really hot in cancer treatment right now, but starting to become more mainstream in other types of other disease states too. So this is all publicly available information. Any one of you guys with the right tools could have gone online and identified these clinical trials and maybe taken the next step and said, okay, well, it looks like they're enrolling in Chicago somewhere, and then let's go to that center and see if I might be a candidate for this trial. So you can do that work on your own. You can have your doctors work on it for you. Certainly, I'd encourage you to participate if you feel the urge to contribute. So I think this is kind of what this says as well. So ask your doctors. They'll probably be the ones that know. Certainly if you're going to an academic medical center, someone that has a university and a medical school, those folks are definitely going to know about what active clinical trials there are. If you go to a private pulmonologist, many of them have my cell phone number. Ask them to give me a call. Or reach out to one of those academic medical centers. And sometimes, I don't want to say private pulmonologists can't participate in these trials. They certainly can. So if you are with a pulmonologist that is really active in the interstitial lung disease space, they may be enrolling in the trial as well. So when would you think about enrolling? So I've got some examples here. So one may be, well, that big list of drugs that we talked about earlier, maybe I've tried all of those, or I don't have side effects with them, and I can't tolerate them, or they haven't worked for me in the past. Maybe at that point you would think, okay, well now let's look at clinical trials. That's something new that I haven't tried before. If you're already on FDA-approved therapy, you may still be eligible. We have patients that are already on one of the medicines that we saw up on that list that still can enroll in many of our open clinical trials. So definitely, if you're interested, please let us know. Which clinical trial design works for you? So some of my patients will tell me, well, I don't want to do one of those phase 2 trials. I really want something that I think is going to work. And so, they're really thinking about, okay, well, what's the phase 3 trials that have already been studied, already been proven to be somewhat effective on phase 2 trials? These are, people get these news releases from, there's some pulmonary fibrosis news sources that I'll hear about all these molecules that I haven't heard of personally in the research world, that somebody's like, hey, they're looking at this in this one center. What do you think about it? And I'll have to go do my homework and read about those medicines. Some people may not want to be involved in a clinical trial where you're taking an experimental drug at all, in which case maybe a registry where we look at you and how things go for you, and you don't have to do anything. You just have to allow us to collect your data. Your personal data, your medical data. All of that data gets de-identified, so you're not going to be at risk of your name slipping out to somewhere, your social security number, your address slipping out. That's all de-identified data that we can look at our patients with scleroderma and follow them long term, and then go back and say, okay, well, we want to know more about how do maybe GI health and lung health correlate, and we've got this novel idea. Let's go back and look at our 800 or so patients in our scleroderma registry and identify what those characteristics might be. And that's very helpful too. We're actively using that data currently for some really cool projects. So I definitely encourage you to be enrolled in a registry as well. And kind of understanding why you're doing this. There are some risks and benefits here, but long term, the only way we can move forward as a field is if we are making progress with these types of treatments or these types of experimental clinical trials. And so understanding that, not to guilt trip you guys, but we really need volunteers for these. So if you are interested, I'm happy to answer any other questions for you. All right, we'll get back a little bit to the clinical side of things here, so thanks for indulging me there. Let's talk about treatments. Let's talk about what we know, what can help, what can make things better. Well, it all starts, the story, back in 2006 with something called the Scleroderma lung study. Back in 2006, we really didn't know much about this disease, about how to treat it. We had a lot of thoughts and opinions. We knew what types of cells were active. We knew the types of treatments that might work, but we hadn't really studied it yet. And initially, the first trial, the Scleroderma lung study 1, examined this drug called cyclophosphamide, or Cytoxan. And so Cytoxan was given over a year, and we watched lung function over that year. And people, again, randomized in this clinical trial to placebo versus cyclophosphamide. 158 patients, 158 volunteers said, yeah, randomize me, give me either sugar water or the cyclophosphamide, and we'll see how it goes. And what did we find? Well, the people on the cyclophosphamide, in general, with regards to lung function, did better. Okay, we'll try to explain some of these graphs, but generally you can understand they did better. The dotted line up here is lung function on cyclophosphamide, and so higher is better, more FVC, more vital capacity, more lung function is better. And then we see these placebo patients that got worse. And I really don't like this graph, but this is the main graph of the paper. And you can see that on the cyclophosphamide, we had 50% of people that got better, and only about 25% of people on the placebo. Okay, so this is great news. This is great news with one big exception, that cyclophosphamide is a really tough drug to tolerate. We can't put people on it long term. So we can really only put you on it for about a year and then take you off of it because we risk those big side effects. And so what happened? Had people on cyclophosphamide for a year and they got better, kept getting better, and then we took them off of therapy right around here and they went right back. Okay, right back to the same lung function that the placebo group had at 2 years. So that's not great, but obviously we found something there. Something was working. But we needed to think about using a medicine that was a little less toxic. And so along comes 10 years later, 2016. So again, think about that clinical pathways 10 years later before we got the next effort, the next randomized control trial. And so this is looking at mycophenolate, which is also known as Cellcept, in not placebo-controlled, but we compared it to cyclophosphamide. And we ran the trial for 2 years. The first year, people on cyclophosphamide were on cyclophosphamide, and then the next year they were off of it because side effects. People on the mycophenolate were on mycophenolate or Cellcept for 2 years. Okay, and you can see that some patients with mycophenolate had to stop because of low white blood cells, but a lot more patients with cyclophosphamide had to stop because of low white blood cells. And lesser patients withdrew from the trial for mycophenolate versus cyclophosphamide due to side effects. So a lot more people couldn't tolerate the side effects of the cyclophosphamide and had to stop. So same types of look here. We've got a 24-month trial here, like we said. And we actually saw that the cyclophosphamide and the mycophenolate group both got better over 2 years. So a little bit paradoxical, not exactly what we saw on the 2006 trial. But both groups got better, and the mycophenolate and cyclophosphamide were about the same. You can see here, these are, again, patients that got better with mycophenolate, 72%. Patients that got better with cyclophosphamide, 65%. Pretty similar numbers, but much better tolerated in the mycophenolate group. Therefore, I'd imagine that a lot of you guys with any scleroderma lung symptoms maybe have been on Cellcept at some point. This is a very common first drug that we prescribe based on what this is a scleroderma lung study 2. So this is, again, we always like placebo-controlled to know if the drug really works, or if it's just the same as the cyclophosphamide, that's helpful, but it doesn't give us all the information. So went back, this is in 2017, Liz Volkman published this paper that looked at a historic group of patients with scleroderma lung disease on nothing, and a group of patients on mycophenolate. And we can see the big improvement in those mycophenolate numbers compared to placebo. So good drug. We use it very frequently. There's some other medications that we sometimes will use as well, and kind of the further, again, we did 2006, 2016, this is 2021, was our first look at a randomized controlled trial of this drug called rituximab, or Rituxan. And this was, again, a randomized placebo-controlled trial. This was really only out of Japan at this point. There were only 56 patients, 56 volunteers that enrolled in this. And we saw improvements in lung function and improvements in, see it on here, I don't think I have it pictured. Oh yeah, this is the skin score. So rituximab looks like actually did not improve the skin score, but did improve lung function here. Okay, so FVC improvement, but not as much improvement in the skin score. The next randomized control trial, again, came out in 2021, and this is looking at a drug called Ofev, a drug that we'd used for years in IPF, idiopathic pulmonary fibrosis, but had not tried in scleroderma before. And we talked about scleroderma. It's a little different than IPF, so wasn't sure that this would work in that patient population. But look how many patients, 570 volunteers, big trial. 50% of these patients were already on mycophenolate. Okay, and so this is on top of mycophenolate in some of these patients measuring lung function change in nintedanib versus placebo. Nintedanib is OFEV. And you can see that even though patients lost lung function on the nintedanib, they were still better off taking the drug than if they were on placebo. All right, so good data here. The bad part of this trial is the side effects. We just got done talking about GI issues with scleroderma. You can see how much GI issues we have with OFEV. 75% of patients on the medication had diarrhea. About 30% had nausea. We see 11% lost weight, and those are all worse on the OFEV. So it's a tough drug to tolerate. If we can tolerate it, though, it does really good. The last clinical trial I'm going to talk about here is called the focused clinical trial, tocilizumab, or Actemra. This is, again, 2019 is this data, kind of coming into a little bit more vogue over the last couple years as well. So this looked at these injections, so not a pill, but an injection of tocilizumab. And they followed people for about a year. And they enrolled 200 patients, so again, another 212 volunteers to be in this trial. And they were really mainly looking at skin score, but they happened to find that patients with the lung function on tocilizumab actually stayed stable, whereas patients on placebo lost lung function over time. Okay, so that's really good. I don't like this graph that much either, but you can see up here, we can say that 75% of people on the, let's see, the placebo had, yeah, see, I don't like this graph very much. 25% of people on placebo lost lung function, whereas only 9% lost lung function in the tocilizumab group. And so we've started using tocilizumab as well in patients who either don't tolerate CellCept or maybe have more inflammatory disease or maybe have more skin issues as well. All right. So those are the trials we talked about. Those are the approved treatments right now. The one thing that I had listed there that's approved for treatment that we didn't talk about, because I'm not the expert on it by any means, is about stem cell transplants. This is a therapeutic that we don't use very often, but we can talk more about it maybe offline over at the table or on break if you guys want to learn more about that. But definitely let's open the floor for questions, and we can talk a little bit about whatever you want to know more about.
Yeah, plenty of time for questions too.
Hi, thank you for presenting.
Yeah.
Just to go back on the Actemra, the primary outcome was the skin score, but did it actually improve?
I don't have it pictured here because I'm not an expert on skin, but our dermatologist, I think, left. So I believe it was a positive outcome, but I don't know the data off the top of my head. Sorry about that. Yes. Good question. So if you have lung disease, I would get a pulmonary function test 2 to 3 times a year at the least. If you have not been diagnosed with interstitial lung disease related to scleroderma, annually would be the recommendation.
So if your scan comes back normal, do you ever need to have another one? Does it mean you won't develop the ILD?
Great question. So a couple ways to answer that. Number one is if it comes back normal, I definitely wouldn't do an annual CAT scan to look for the presence of interstitial lung disease. You could certainly talk to your doctor and make an individualized treatment plan, but the other piece of data is that early on in the diagnosis of scleroderma is the most common time you're going to be diagnosed with interstitial lung disease. And so if it's not present early on, it's unlikely to develop down the road. Yep.
Hi, going back to that scleroderma and lung disease slide, we had pulmonary function tests, and with HRCT, I didn't quite get a definition of that.
Sure. So about what an HRCT is?
Yes.
Yeah. Thank you for asking that question. It is an important piece of information that I didn't talk much about. So there's a lot of different types of CAT scans. I alluded to a couple of the screening ones already, the coronary calcium screening scan or a lung nodule screening test. These are all different protocols within a CAT scan machine that the radiologist and the radiology technician will put you through. Some of them have more radiation, some of them have less radiation. The high-resolution CT is one of these protocols that we use in the lung disease world to try to help us answer why someone has interstitial lung disease, and sometimes it can be very helpful for identifying what type of problem is going on. And there's 3 different phases to the high-resolution CAT scan. First off, high-resolution I always kind of refer to as high def. Like nobody, you guys are, any kids these days don't know what not high def is. You guys know when high def came out, that was revolutionary, right? More pixels, we can see things a lot clearer. That's kind of the same thing with high resolution, is that we take smaller slices in between segments of the lung. Now, technology has changed a little bit over the years to where I think most CAT scans are high def these days, just like most TVs are high def. The different parts of the high resolution CAT scan, or the ILD protocoled CAT scan, are the first one, which is the kind of the part that everybody gets with pretty much any CAT scan of the chest they get. Take a big deep breath in and hold it, and then go through the CAT scan. Okay, and we want that full inspiration, full big deep breath. The second part that we do is we have you blow all of your air out, as much as you can, and then go through the CAT scanner. And that helps us identify things like air trapping, which can be useful for identifying things like lung disease related to mold or bird feather exposure called hypersensitivity pneumonitis. Most of the time, in folks with already existing autoimmune disease, will associate that lung problem with that autoimmune disease, but that's not 100% the case. We always have to look for risk factors for mold and other exposures. The third part of that CAT scan, we have you flip onto your stomach, and we do it in the prone position, which is just going through a CAT scan upside down. And the idea with that is some very mild lung disease can exist on the bases of the lungs. Here, let me show you on the picture. Like back here, okay, just on that part. And if it's just very mild and we see some of those changes there, it could just be gravity, right? Kind of laying on your back and having some compression of those areas of the lung can look abnormal. So we flip you on your stomach, and when we turn you on your stomach, it gets rid of gravity as a problem. And some of those lung changes may go away if it was just gravity, or those lung changes may persist if there's really scarring or interstitial lung disease there. So that's what that high resolution means, is all of those different things. That's fine. I'll repeat the question. Yeah.
I was wondering, like, how long has that recommendation been out to have a lung scan? Because I've never had one.
Yeah.
And then if the doctor recommends it, can insurance still refuse it?
Good question. So the question is about how long have we recommended getting a screening CAT scan, and what are the intricacies about, is insurance going to pay for it even? It's really only been out about 6-8 months or so. We wrote it in 2023, but it took, for whatever reason, a bit longer to come out, so just 2024 guidelines. Insurance should pay for it, although certainly insurance can be fickle. And I have many times had to say, well, they'll call me and they'll say, well, you need to get a regular chest x-ray first. And like I told you guys, that's very unhelpful. And so I tell the insurance company, I was like, I mean, I can get one if you need one, but it's not going to help me, and I'm going to order the CAT scan anyway. Now we can at least point to these guidelines and say the guidelines from the American College of Rheumatology say this, and then they'll usually approve it. But it does require sometimes a phone call from me to the insurance company, or my nurse to the insurance company to make that happen. Yeah.
So I don't have interstitial lung disease. I've got bronchiectasis and small airway disease.
Yeah.
And I got on Google, and of course I can find an association between systemic sclerosis and bronchiectasis, but I don't see very much about that, and it could be just that, somebody wrote something. I'm interested in your opinion about that.
Well, the good news for you is I don't have an opinion. I have some facts for you. So actually, this is really interesting. You're kind of like a plant in the audience. This is we're submitting an abstract to the American Thoracic Society for our scleroderma registry and looking at exactly this, incidence of airway obstruction or bronchiectasis, and we see it very commonly. The data I don't have off the top of my head, but we're publishing on that in the next few months. So really very commonly associated with any autoimmune disease, these airway-centric issues. It's come into the guidelines a little bit and causes a bit of confusion, so we're hoping to define it a little bit more, looking at some of those pulmonary function tests that we don't usually look at, and identifying, just like we talked about that high-resolution CAT scan, those expiratory images can sometimes tell us a lot about air trapping. And when we see that air trapping, we're using that as kind of our source of truth. When we see that and we can correlate it with those pulmonary function test findings and define how frequent that is in scleroderma. But it is more present in scleroderma than other lung diseases and in normal health. Yeah.
Any other questions? Wow, we're done early.
All right.